I think it's going to be a real challenge figuring out which patients are best suited for transcatheter valve implantation. You know, the groups that would clearly benefit the most are those who are inoperable by current standards, where we now have an option to offer them that would prevent the recurrent hospitalizations for heart failure that they have otherwise, and the very high 50% one-year mortality. But even in that group, I think we're going to have to be careful to make sure that these are patients who have a reasonable life expectancy and are going to benefit from the procedure. That is, they don't have other conditions that are going to shorten their life at that point. Mm-hmm. The second group is going to be the high-risk surgical patient who, in theory, can undergo surgery but at high risk. And in those patients, you know, the cohort A would suggest that we have the option of transcatheter versus surgical implantation in those patients. But beyond that, I'd probably stick with those two groups for now, because I think clearly transcatheter valve implantation is here to stay. That's an impressive valve. It restores fairly normal hemodynamics, relieves stenosis, but we don't know long-term valve durability, and I think that's going to limit our applying it more widely in the immediate future. I think at the very, very elderly stage of life, if patients have other comorbidities that are going to limit their life, that the transcatheter valve, we'd have to say, is it going to improve their quality of life for the remainder of their life? Is it going to prolong their life, and weigh that in the decision? I think when we think about younger patients with aortic stenosis and younger patients in their 70s and certainly 60s, you know, we have to remember that people have a long lifespan, that even as we reach our 70s, we have many more years of active life, and we want to have a durable valve. And right now that still means surgical valve implantation until we have more data about transcatheter valves.